I know. You're okay?
I joined the Caribbean College of Family Physicians, CCFP,
I they
your
have
pathway to
shot
professional growth, recognition,
therapies.
and global networking. As a member of the Caribbean College of Family Physicians, CCFP, you become part of an elite network committed to advancing family medicine across the Caribbean. Membership opens the door to local, regional, and international opportunities for professional development, accreditation, and leadership in primary care. Earn CCFP CMEs, recognition that counts. The Education Committee delivers a 3-year curriculum tailored to the realities of family medicine practice across the region. Achieve your MCCFP certification by completing a minimum of 50 CME hours annually, 150 hours over 3 years, to earn certification, a respected professional credential locally, regionally, and internationally. The MCCFP designation, a pathway to professional recognition. For physicians who have successfully completed the Doctor of Medicine, DM, in Family Medicine program, an important next step in professional development is obtaining the MCCFP designation through the Caribbean College of Family Physicians, CCFP. The MCCFP designation signifies that a physician has met the standards established by the College for Postgraduate Training in Family Medicine and demonstrates a commitment to continuing professional development and lifelong learning. Physicians who apply for membership in the Caribbean College of Family Physicians within 3 years of completing their DM in family medicine are eligible for full membership and are awarded the MCCFP designation upon admission. Physicians applying after this period may still obtain the designation by demonstrating compliance with the college's continuing medical education requirements. The MCCFP credential serves as a recognized professional qualification within family medicine and provides evidence of ongoing engagement in continuing medical education, professional standards, and regional collaboration among family physicians. The college requires members to maintain continuing medical education activities and remain in good standing in order to retain the right to use the MCCFP designation. For graduates of the DM Family Medicine program who aspire to specialist recognition, the MCCFP designation represents an important professional milestone that demonstrates commitment to excellence in family medicine, quality patient care, and lifelong learning throughout their careers. We encourage all family medicine graduates to become active members of the Caribbean College of Family Physicians and to pursue and maintain the MCCFP designation as part of their professional journey. Access a rich calendar of CME opportunities, monthly workshops on seminars, and an annual family medicine conference. Monthly CME meetings with certification. Online CME courses and training modules in collaboration with recognized regional and global health bodies. Tri-annual Pan-Caribbean conferences and WONCA international and regional conferences. Diverse, high-quality educational content. Our CME programs cover clinical updates in hypertension, diabetes, obesity, HIV/AIDS, and occupational health. Disease management guidelines from PAHO, WHO, CAREC, and CHRC. Evidence-based approaches to disability management, patient safety, and community health. Local, regional, and global connections. Collaborations with the University of the West Indies, UWI, Caribbean Food and Nutrition Institute, CFNI, ACOM, ICOH, and other leading institutions. Opportunities to present and publish peer-reviewed research at regional and international conferences. Flexible CME credit earning. Members can earn credits through group learning, workshops, seminars, symposia, hospital grand rounds, individual learning, online courses, journal clubs, publications, presentations, and voluntary community work. A commitment to lifelong learning. CCFP members benefit from structured guidance, CME tracking, and annual submission of CME credits, ensuring compliance with the highest professional standards. Join the CCFP today. Elevate your practice, expand your network, and gain the professional recognition you deserve. Contact the Secretariat to start your membership journey. Why join the Caribbean?
Good afternoon, good afternoon, good afternoon, everyone. Thank you so much for joining us for part two of this wonderful series. My name is Samuel, and the Caribbean College of Family Physicians Jamaica chapter welcomes you. I'm going to hand you over now to our moderator for the session. That's Dr. Pauline Williams Green, who will guide us through today. Dr. Williams Green, over to you.
Good evening, everyone. What a wonderful evening. Searing heat outside here in Kingston. 42 degrees, my car said. Football inside. And then we have this wonderful presentation ahead of us. Let's ask Dr. Arlene Henry Dawkins to offer prayers.
Good evening, everyone. May we welcome the presence of Almighty God, Jesus Christ, and the Holy Spirit as we bow our heads in prayer. Our loving, awesome Father in heaven, we are grateful for your many blessings and love. We thank you for this opportunity to again share relevant and useful information through this virtual conference hosted by the Caribbean College of Family Physicians, Jamaica, on healthy aging and prevention of non-communicable diseases. Dear Lord God, growing older is a reality everyone must face, and with improved healthcare and better lifestyle practices, the increase of the aging population is evident, with longer life expectancy noted. Help us, as health practitioners, to become better equipped to assist with prevention of diseases that affect longevity and to ensure that the best management of the various health challenges affecting quality of life for this population is offered. Grant us wisdom and skill to ensure that the body, mind, soul, and spirit are attended to as we care for the elderly with understanding, compassion, and patience. May your presence be welcomed in their lives, so that as your word declares, Beloved, I wish above all things that thou mayest prosper and be in good health, even as thy soul prospereth. Father, may we also, as health workers, not forget to care for ourselves and embrace the same practices which will allow us to age gracefully and healthily. We pray that the Holy Spirit will lead and guide all the proceedings tonight. May He grant wisdom to all the presenters as they expertly share their knowledge on this important topic. May our thoughts and discussions be inspired by you as we attentively receive all the valuable information presented. Grant, Lord, that as we learn, we will capably utilize the knowledge to enhance the quality of life for the vulnerable elderly.
All right, I think we missed the amen. But I want to thank Dr. Arlene Henry Dawkins, Executive Board Member of the CCFPJA, for prayer. Just before we go any further, is there a pretest, Sam?
Sorry about that. I was unmuting. No doubt, no pretest.
Okay, so all right, so we don't get a pretest and we still get our CMEs. Wonderful, because we will be in attendance, you'll be taking notes, and you have your questions as they come along. We will now go on to the greetings. And overview by Dr. of the CCFP Jamaica.
Thank you, Doc. I'm going to play a video now from Dr. Ononuju.
Good afternoon, everyone. I am Dr. Seni Ononuju, President of the Caribbean College of Family Physicians, Jamaican Chapter. On behalf of the Executive Board of the Caribbean College of Family Physicians, Jamaican Chapter, it is my distinct pleasure and honor to welcome you to the final installment of our Healthy Aging and Non-Communicable Disease Virtual Conference Series under the theme Prevention, Precision, and Healthy Aging in Primary Care. As family physicians and primary care practitioners, we are privileged to work alongside our patients through every stage of life. Our role extends beyond diagnosing and treating illnesses. It includes helping individuals remain healthy, functional, and independent for as long as possible. The topics being discussed throughout this series have therefore been highly relevant to the realities we face in our clinics and communities every day. The knowledge we gain from activities such as this does not remain within the virtual walls of a webinar. It is translated directly into patient care. When our patients visit our offices seeking guidance on weight management, chronic diseases prevention, healthy aging, or concerns about unnecessary testing and treatment, they expect evidence-based advice and thoughtful clinical decision-making. Today's presentations will further strengthen our ability to provide and care with confidence and compassion. This afternoon, we are honored to welcome two distinguished presenters. Our first presentation will be delivered by Professor Trevor Ferguson, Professor of Epidemiology and Internal Medicine, who will speak on obesity as a chronic disease and modern approaches to its management. Obesity remains one of the most significant drivers of non-communicable diseases, and we look forward to hearing practical and evidence-based approaches that can help us improve patient outcomes. We will also be privileged to hear from Professor Masha Toloreid, Professor of Epidemiology and Endocrinology, who will present on medical overdiagnosis and overtreatment, improving clinical decision-making. This important topic challenges us to continually reflect on how we can provide the right care at the right time for the right patient. I would also like to recognize our moderator for this afternoon, Dr. Pauline Williams-Green, family physician and executive member of the Caribbean College of Family Physicians Jamaican Chapter, who will guide us through today's program and facilitate our discussion session. At the conclusion of the webinar, the vote of thanks will be delivered by our Secretary, Dr. Dane Levy, whose unwavering commitment to the work of the chapter continues to contribute significantly to our success. I wish to express sincere appreciation to our sponsors, Abbott Nutritionals and Indus Life Sciences Limited, for their support of continuing medical education and their partnership in helping us deliver programs of this caliber to healthcare professionals throughout Jamaica and the wider Caribbean. Behind every successful webinar is a team of dedicated individuals working diligently behind the scene. I therefore extend heartfelt thanks to our information technology support team, whose expertise ensures that these virtual events run smoothly and professionally. I also wish to recognize our hardworking CCFP Jamaica Communication and Administrative Support Secretariat staff, whose planning, coordination, communication, administrative support make activities such as these possible. To my fellow executive board members, faculty members, presenters, sponsors, volunteers, and partners, thank you for your commitment to advancing family medicine and primary care. Most importantly, I would like to thank all of you, our attendees. Your participation demonstrates your dedication to lifelong learning and providing the highest standard of care for your patients. Educational activities are only successful when healthcare professionals are willing to invest their time, engage in discussion, and apply new knowledge to practice. Your presence here today is therefore greatly appreciated. As we bring this conference series to a close, I hope that the information shared over these sessions will inspire meaningful changes in practice and encourage continued conversations around prevention, precision medicine, and healthy aging. Together, we can help our patients to not only live longer lives, but to live healthier and better lives as well. Thank you for joining us this afternoon. I wish you an engaging, informative, and enjoyable session and welcome you all to the Healthy Aging and Non-Communicable Disease Virtual Conference Part 2. And as always, God's richest blessings.
Dr. Seni. I was introduced earlier, and I think most of you know me. I'm Dr. Pauline Williams Green. This is me. However, I'm going to cut off my video because I'm getting a message that my bandwidth is low and I don't want to disappear on you all. So if you don't mind just listening to my voice for now. I want to reiterate all the welcome that comes from Dr. Seni Ononuju. While we're at it, this has really been an exciting two-part series, as she mentioned, and I see that there are those nearby, or rather those listening, who would like to get the first session on demand. And then we will remind you of how to do that. You'll send an email to the Secretariat and they will get you going with the on-demand session. But you definitely don't want to miss it. All right? So we're actually a few minutes early because our paper says that we would start with Dr. Ferguson at 3:30. Sam, is he on?
Right. Yes, I am.
Wonderful. I love that voice. Very calm. You just whenever you've just been told you have kidney failure or you had diabetes that none of your GPs can control. This is as a patient, this is a voice you want to hear. So we're going to introduce the Professor um, Trevor Ferguson, and he doesn't mind me teasing him. He has as many letters behind his name as the letters of the alphabet, and I counted them, colleagues. Trevor Ferguson is a professor of epidemiology and internal medicine and director of the epidemiology research unit, the Caribbean Institute for Health Research, and at the University of the West Indies. He is also honorary consultant in general internal medicine at the University Hospital of the West Indies. He holds, of course, an undergraduate medical degree, a doctor of medicine in internal medicine, and a doctor of philosophy in epidemiology from UWI. He holds an MSc degree in epidemiology from the University of London. He is a fellow of the American College of Physicians and the Royal College of Physicians of Edinburgh, and a Bernard Loan Scholar in Cardiovascular Health at the Harvard T.H. Chan School of Public Health. And he currently chairs the Jamaica's National Committee on Non-Communicable Diseases. Of course, he's an investigator, has over 100 publications which are peer reviewed. And you wouldn't believe it, he still finds time to go to church. And he insists that he goes to church no matter what. So I love him for that. Please take over, Prof. I hope I don't disappear. I'm listening though.
Okay, thank you very much, Dr. Williams Green. Certainly a pleasure for me to be here and to share with the Caribbean College of Family Physicians. Thanks again to Dr. Onanuja and the team for inviting me to participate. Well, to be honest, I tried to avoid it, but no wasn't taken as an answer. So despite all my other commitments, I am very much here and willing to share. Let me see, just to confirm that you can hear me well and you're also seeing my screen.
Confirmed.
All right, good. I need to get this floating wind
Yes, sir.
to move. Just one more thing. All right, that can go up there. All right. So the topic for this afternoon is obesity as a chronic disease, modern approaches to management. Just one little thing. Let me see. I can hide gluten. All right, good. So, just to give an outline as to what we will talk about today, just very briefly on some of the global and local epidemiology for obesity. Also, to look at an overview of the pathophysiology of obesity, a reminder of some components of the clinical evaluation of the obese patient. We'll speak briefly on lifestyle approaches to the management of obesity, a quick update on pharmacological treatment for obesity, and a mention of bariatric surgery. Given that we have 30 minutes, none of these can be done in great detail, but it will give us a clear overview as to the approach to the management of obesity at this time. So one of the first things that we need to recognize is that there's a need for paradigm shift in practice. And it's important that as physicians, we recognize that obesity is a complex, multi-organ, relapsing biological illness, and it is not a moral failure or lack of willpower. So it's not a simple energy in, energy out equation that, of course, if we try hard enough, we will get it done. But there are several factors that contribute to the development of the obesity, and therefore we need to see it for that and treat patients in such a way. So the physician should provide stigma-free care. The physician's role is to construct a non-judgmental therapeutic relationships, targeting the visceral pathology and long-term prevention, rather than, of course, making the patient feel that it's all their fault why they are obese. So what is the state of affairs? And this is data from the WHO looking at the key facts concerning obesity, data from 2022 up to 2024. And what they reported that in 2022, 1 in 8 of the world population was living with obesity. Worldwide, obesity had prevalence has more than doubled since 1990, and among adolescents, obesity has quadrupled. In 2022, there were 2.5 billion adults 18 years and older who were overweight, and of these, 890 million were living with obesity. Again, in 2022, 43% of adults 18 years and older were overweight, and 16% were living with obesity. In 2024, there were 35 million children under age 5 who were overweight, and 390 million children and adolescents between the ages of 5 to 19 years were overweight in 2022, including 160 million who were living with obesity. So this is clearly a global problem and one that needs to be approached with care and concern. And of course, we need to find effective solutions and ensure that those solutions can reach the larger population. So what about the situation in Jamaica? Here we show data from the Jamaica Health and Lifestyle Survey 2016 to 2017. And most persons who have heard me speak but may have seen a bit of this data before. Overall, 54% of persons 15 years and older were overweight and overweight or obese. 25% falling in the overweight category, 29% in the obese category. And this was much higher among women compared to men. So for obesity, prevalence of obesity among males was 14.9%. And among females, 41.2%. Overall, 29% of the adult population, 15 years and older, would be classified as obese. As we mentioned, there was marked sex difference throughout all the age groups, and we see that obesity prevalence peaked in middle age between 35 and 64, and then gradually decreased among the older adults. And of course, we can see a gradual increase among those 15 to 24 and among those 25 to 34. But in every age band, there was significant prevalence of obesity and of course, a cause for concern. We have some updated data from the Jamaica Soil Consumption Study, which we conducted between 2022 and 2023. And unfortunately, the data are not encouraging. So when we looked at the prevalence of obesity among males, overall 16.9% were obese and 38.8% were overweight. So, did I say it? Yes, 38.8% were overweight. Among female, 46.2% were obese and 73.3% in terms of overweight and obesity combined. So what this would suggest is that the situation may be worsening compared to what we saw in 2016, 2017. Just to note that we are currently in the field for the Jamaica Health and Lifestyle Survey 4, so we will have updated estimates by early next year. But clearly, if the trends that we're seeing from the Jamaica Soil Consumption Study are correct, it suggests that obesity prevalence is worsening, and therefore we are likely to have a more significant problem as we go on. The pattern is similar to what we saw in the Jamaica Health and Lifestyle Survey, with peak incidence in the 35 to 54 and 55 to 74 age bands. Fewer persons among those older than 75 were overweight or obese. And there was a slight higher prevalence among rural residents, which of course is something that we would also need to note. So where does Jamaica stand in relation to the other countries within the region? Fortunately, at least at this in 2016, 2017, the data suggests that Jamaica's obesity prevalence was in the sort of a mid-range for the Americas. The overall regional prevalence in the Americas was 33.8%, whereas Jamaica was 29.8. Highest prevalence was in the Bahamas at 47%. The US were also very high at 36.2%. And Guyana, well, from this list, had the lowest prevalence at 27.4%. But as we can see, that this is not just a Jamaica problem or a Caribbean problem, but clearly a regional problem that needs to be addressed. Now, why are we concerned about obesity? If so many people are overweight and obese, is it that this is just a variation of normal, or is this true pathology? The essence of the story is that obesity is associated with a number of clinical conditions and results in worsening morbidity and mortality. So this slide shows some of the conditions associated with obesity, and we can see that it spans the spectrum of pathophysiological categories. So we have the metabolic diseases, so diabetes, dyslipidemia, hypertension. There's the association with heart disease, stroke, thromboembolism, cancers, and we'll say a little bit more about cancers in the next slide. There's association with osteoarthritis, gout, liver dysfunction for the metabolic dysfunction associated steatotic liver disease, or MASLD as it's now commonly called, GERD, infertility, polycystic ovarian syndrome, sexual dysfunction, chronic kidney disease, kidney stones, urinary incontinence, depression, dementia, obstructive sleep apnea, asthma, as well as infectious conditions. So it is not okay to say that obesity is a benign condition, but the association with these multiple abnormalities means that it's a marker of risk which we need to look into and to address. As mentioned, obesity is associated with several cancers, including meningioma, cancer of the esophagus, myeloma, kidney cancers, endometrial cancer, ovarian cancer. It's associated with thyroid, breast, liver, gallbladder, stomach, pancreas, and colon cancer. So again, a large number of cancers associated with obesity and is of clinical significance. So this is one of the important slides that I think persons will need to look at, is that the studies show a clear association with increased morbidity with obesity. So here we see that the lowest morbidity or mortality was those somewhere between a BMI of 23 and 25. And once you went above 25, then there was a gradual increase in mortality. And from this study, it was estimated that above a BMI of 25 kilograms per meter square, mortality was on average approximately 30% higher for every 5 kilogram per meter square increase in BMI. So there's a clear association with higher mortality, and therefore one needs to address this as a significant clinical problem and not a benign disorder that we should, we may or may not treat. Now, understanding the pathophysiology of obesity is quite important because, as I mentioned at the beginning, our original concept was largely an energy in, energy out kind of paradigm. And because of that, it resulted in a lot of patient blame. Now, what is important is to recognize that obesity is indeed a complex disorder with several contributing factors. There's a clear genetic predisposition, and studies estimate that the heritability of obesity is between 40 to 75%. and they are both polygenic and monogenic inheritance patterns. And of course, there are some conditions such as leptin deficiency and Prader-Willis syndromes, which show monogenic inheritance patterns. So these tell us that there are pathophysiological mechanisms involved in obesity, including the genetic factors that must be taken into consideration. Then there are the neuroendocrine factors, including the hormones secreted by the adipose tissue and other endocrine controls such as leptin and ghrelin, which we'll talk about in a little while. The thyroid hormones also plays an important role in the weight maintenance and prevention of weight gain. And of course, the gut hormones, including GLP-1, which is an area of great interest in recent times. So this slide shows an overall approach to the homeostatic regulation of body weight. And what we can see here is that for most people, body weight will remain fairly stable over time despite fluctuations in the amount of food we eat and the levels of activity. Now, as mentioned, there's this neuroendocrine regulation of body weight, which is controlled centrally by neurons in the hypothalamus, which receive hormonal signals from adipose tissue such as leptin and neural and hormonal signals from the gut in response to meals. And what these do is control appetite and satiety. And of course, if satiety is not adequately recognized, we will continue to eat. And of course, continuing to eat will lead ultimately to caloric excess. Now, glucagon-like peptide 1 or GLP-1 and other gut hormones are secreted in the from the gut in response to a meal, and these will send signals to the hypothalamus to stimulate satiety and therefore will reduce eating. Now, additionally, other hormones such as insulin will have effects on the hypothalamus, and then release of ghrelin from the stomach increases in the unfed state and induces appetite by acting on the hypothalamic neurons and receptors in the brainstem. So we see the roles then of leptin, ghrelin, GLP-1 as important hormones in the regulation of satiety and appetite, and the balance between these will determine whether or not one continues to gain weight or weight remains stable. But one of the main concerns is that over time, the body will actually adjust its metabolism in an attempt to maintain weight. So a person who loses weight may result in a slowing of the metabolism to maintain and defend that weight, and therefore weight loss becomes a challenge even for persons who are trying to make that difference. Now, in addition to the biological determinants of obesity, it's also important for us to recognize that there are social and commercial determinants of obesity. And essentially, we live in an obesogenic environment. So despite sometimes the best will, people find it difficult to make that balance between appropriate nutritional intake and to avoid excess calories. So why is this so? This has to do with the whole nutrition transition and changes in trade policies, where now most food is pre-prepared, ultra-processed, and these are freely is not the right word, widely available in most Western countries, and these are often lower cost than high quality unprocessed foods. So we have these highly processed foods, calorie dense, that are widely available and become the main source of nutrients in many countries. These have displaced the traditional high fiber root crops such as yams and green bananas, callus, etc. And therefore, we find that people are consuming more calories in each meal. Additionally, there's the issue of food insecurity, where persons with lower resources are more likely to purchase these energy-dense, nutrition-poor processed foods, and because they are more affordable, and again result in calorie excess and increase in obesity. So in addition to the individual biological and physiological issues, there's the need for a social, and governmental response that will ensure that we are also addressing the obesogenic environment. There are other factors, including cultural factors. So larger body size have been often been seen as representing physical health and prosperity, and therefore there's often a cultural resistance to weight loss because people feel that they look better when they have more weight. There's also the issues with urbanization and reduction in active transport, so that people are doing more motorized transportation, spends lots of times in sedentary work environments, and then they are traveling in cars and buses to work, and therefore there's not very much energy expenditure within the regular work environment. And often the built environment does not provide safe walking spaces and resulting in reduced physical activity. So these social, cultural, and commercial factors have a significant influence on obesity, and any obesity policy need to ensure that these factors are addressed in addition to the individual level behavioral factors, which we will talk about in a little while, pharmacological treatments, or the surgical treatments, because if we do not address these underlying social determinants, we will continue to have significant increases in obesity. And of course, we can look at more pharmacological treatments, but those we may have to deal with side effects, costs, etc. So the social and commercial interventions are going to be critical part of the response. So that takes us through the overall in terms of what is happening in terms of the etiology of obesity. But given that we have so many people with obesity in the country, you will see, or we will see, many of these patients in practice. And it's important that when we see the patient, that we have a discussion on weight management. We will need to do various history and physical examination components to determine whether or not there are underlying causes, and to address these as part of the overall clinical plan. So, was that an intervention? Everyone hear me well?
Go right ahead. We're hearing you well.
Okay, good. All right. So this slide looks at what is called the 5A weight loss counseling. So one of the things, of course, is that patients will come to you or come to us for other conditions, and weight may not be part of their problem list. But of course, we should be weighing patients at each visit, and we should have the height done at least the first visit. So we should have an indication as for each person's weight and height, and therefore should be able to classify them as normal weight, overweight, or obese. So that information should be available to us before the patient comes in for the formal consultation. So when we recognize that a patient is overweight or obese, it's important that we ask permission to discuss weight. So it might not have been among their problem list, but we should initiate that discussion. We should assess weight-related health risk. So, of course, ensuring that we are documenting BMI, abdominal obesity, and also whether or not there are weight-related conditions that should be addressed. We should provide advice on weight loss, giving realistic and individual goal-based starting weight and individualized goals based on starting weight and related health conditions. It's important that the patient agrees on the specific goals for diet and physical activity. And where necessary, we can assist with referral to a program for diet, exercise, with a prescription for medications if indicated. And if necessary, also schedule a weight-focused follow-up visit. So what are some of the things that we need to look for in the history as we evaluate the patient with obesity? So it's important to take a weight history. Did this patient have obesity from childhood, or was it a more recent weight gain? Of course, if there is sudden weight gain, that may indicate a greater likelihood of some underlying disease condition promoting weight gain, and therefore that would be important to get the weight history. We should find out about weight loss goals and whether or not they have had previous attempts at diet and exercise and what was the success or lack thereof with those efforts. Medical history for weight-related conditions, diabetes, arthritis, and looking at things that may be contraindications to weight loss medications that we may be introducing. We should have some information on their dietary history and eating behavior, recognize sources of excess calories, and be able to direct the participants or the patients as to appropriate changes. Information on exercise and physical activity, information on psychosocial factors that may contribute to challenges with weight, experiencing weight stigma, whether or not patients have had history of abuse or trauma, and other factors that sometimes may cause that weight eating may actually be a sort of a behavior to deal with some of those psychological factors. Sleep history, including risk for obstructive sleep apnea, which may be a major contributor to weight gain, etc. And of course, looking at other factors like mood disorders, looking specifically for things like Cushing's syndrome, PCOS, and so on. So it's important to have a comprehensive history. We should look at medications that may contribute to weight gain, glucocorticoids. Remember, several of our diabetic medications promote weight gain, including insulin, the sulfonylureas, thiazolidine gliones, and meglitinides. Some patients with psychiatric disorders on medications such as the olanzapine, quetiapine, risperidone, etc., that may promote weight gain as well. Some antihypertensive medications like beta blockers, anticonvulsants used for chronic pain, gabapentin, pregabalin, antidepressants, progesterone-based contraceptives, first-generation antihistamines. So all of these are medications that may contribute to weight gain, and where feasible, we can replace them with medications that are likely to produce less weight gain, as we see in this slide. And then, of course, in our physical examination, looking for some specific factors that may point to underlying conditions. So things like acne and hirsutism may suggest PCOS, achondrosis nigricans may suggest insulin resistance and type 2 diabetes, abdominal striae may suggest Cushing's syndrome, etc. Increased neck circumference, it suggests increased risk for obstructive sleep apnea. Thyroid nodules or goiter may suggest thyroid disease. Of course, we're going to be evaluating their cardiovascular system, looking at the extremities, eyes, musculoskeletal system, etc. So again, what it means is that we do need to have a comprehensive physical examination looking for abnormalities, because these may point to conditions that may be unrecognized and would be important for us to address. All right, so moving on to management, and the 3 pillars of obesity management includes psychological and behavioral intervention, pharmacological treatment, and bariatric surgery. And we will go through each of these quickly. So just a few weeks ago, the American Heart Association, American College of Cardiology, American Diabetes Association, and American Society of Nephrology published guidelines for the prevention, detection, and management of cardiovascular kidney metabolic syndrome. And included in this guideline is a section focused on the management of obesity. I will present some of the recommendations from this guideline as part of the overall approach to correct management. So these were the recommendations for the overarching approach to obesity management. Firstly, that among adults with overweight or obesity, lifestyle modification is recommended as a first-line strategy to alleviate weight loss of at least 5 to 10% from baseline weight. So we emphasize that lifestyle modification is the first strategy. Among adults with overweight or obesity receiving weight loss counseling, a non-judgmental approach to initiating weight loss discussion is recommended in order to increase the effectiveness of weight loss. And among adults with obesity, integrated interdisciplinary weight management teams can be effective to enhance patient-centered approaches to weight loss. So again, it's important that this lifestyle modification is important, a non-judgmental approach, and pull in other team members to assist with the care of the patient. With regards to lifestyle modifications, the recommendations included that among adults with overweight or obesity, clinicians should provide counseling at least annually regarding the benefits of achieving at least a 5 to 10% weight loss for CKM syndrome risk reduction. Among adults with overweight or obesity, clinician referral to in-person or virtual multi-component behavioral intervention is beneficial for promoting weight loss. For adults with overweight or obesity who have significant barriers to participating in multi-component behavioral weight loss intervention, self-directed digital health solutions can be beneficial. Number 4 with intensive lifestyle is that lifestyle modification that incorporates moderate caloric restriction and regular physical activity should be recommended to promote weight loss. And then among adults who have successfully lost weight, long-term weight management programs that in part emphasize increased physical activity should be recommended. So the long-term management is important because we know that many patients after initial weight loss tend to regain weight. In terms of the specific dietary patterns, the dietary patterns that are beneficial, including DASH diets, the Mediterranean diet, pescatarian diet, or vegetarian diets. These produce notable cardiometabolic benefits, specifically reducing the risk of hypertension, reducing the risk of type 2 diabetes, reducing the risk of cardiovascular disease. So these are the dietary patterns that we would like to recommend. Low fat and low carbohydrate diets are also important. These have modest impact on weight loss, usually about 4 kilograms, show significant blood pressure reduction in clinical trials, but often the benefit tends to disappear after about 12 months due to diminishing adherence to those patterns. So time-restricted eating or intermittent fasting is another approach that has shown to be effective. It does demonstrate weight loss efficacy, more effective than standard calorie-limited diets for weight loss and for improving cardiovascular risk. And for many, it is easier to manage and maintain than some of the other approaches, which looks at cutting out specific nutrients. A note of concern is that the ketogenic diet, that while this may reduce weight, may cause severe hypercholesterolemia and therefore could end up with an increased risk rather than reducing the risk. So the ketogenic diet is not recommended as a primary approach for weight loss and reducing cardiometabolic risk. So what about pharmacological treatments? The recommendations from the ACCHA guidelines in adults with stage 1 CKM and overweight and obesity, with or without metabolic risk factors, the addition of GLP-1 based therapy with proven benefit to structured lifestyle intervention can be beneficial in promoting weight. So GLP-1 based therapy is among the most recommended. In adults with CKM stage 1, the addition of GLP-1 based therapy with proven benefit is projected to be cost effective. So while the medications may cost a lot in the early stages, the cost effective analysis suggests that they are worthwhile. And for persons with CKM stage 1 as well, GLP-1 based obesity pharmacotherapy may be reasonable to use for the promotion of weight loss. So what are the pharmacological agents that we have in the management of obesity? So as you can see, the GLP-1 agonists are among the newer agents. Semaglutide, tirzepatide have been shown to achieve significant weight loss in the region of 15 to 21%. Additionally, they have significant cardiometabolic benefits, not only reducing weight, but reducing cardiovascular disease and kidney disease. They have significant gastrointestinal side effects, and therefore we have to take those into consideration. The weight loss benefits may reverse after cessation of therapy, and so forth. That needs to be taken into consideration. In addition to the GLP-1, there are several other FDA-approved pharmacological treatments that can be considered. So these include medications such as orlistat, centrally acting agents such as phentermine topiramate, and naltrexone bupropion. All right, and I'm going to skip this slide in terms of time. I think I'm a little bit getting over my 30 allocated minutes. So let's go to this slide that looks at the benefits and some of the side effects of the specific agents. So for tirzepatide, produces at least a 15% weight loss above placebo. Maximal weight loss is about 1%. Common side effects include nausea, diarrhea, constipation, and these should be avoided in people with type 2 multiple endocrine neoplasia or a history of pancreatitis. And these contraindications apply to all of the GLP-1 agonists. The GLP-1 agonists will also reduce blood pressure and reduce A1C, reduce the lipids as well. So there's overall net benefit. Phentermine topiramate has a roughly 8% average placebo-corrected weight loss, maximal at about 13%, is associated with increased heart rate, dizziness, dry mouth, constipation, limited dose for persons with reduced GFR, avoiding people with coronary heart disease, and abrupt withdrawal could result in seizures. So it has to be managed carefully. The naltrexone bupropion are about 4% placebo-corrected weight loss. Orlistat is about 3% corrected placebo-corrected weight loss, but may go as high as 10%. And phentermine by itself, again, 3 to 5%. So these other agents do have benefits, but they are less effective as compared to the GLP-1 agonist. I'm going to skip the details here because I'm trying to manage the 30 minutes well. Um,
30 minutes has gone.
all right, so let me go to my very last slide then. So, just to say the role of bariatric surgery, the overall, what we see is that for those who are not able to manage with the oral medications, or if there are other specific indications, then bariatric surgery would be another option. The methods include things like sleeve gastrectomy, Roux-en-Y bypass, the adjustable gastric band, and biliopancreatic diversion. So these are all procedures that can be used and have been shown to be effective in weight loss. And therefore, these are, well, there are several surgeons who are now offering bariatric surgery locally. And therefore, for carefully selected patients, this may also be an option. So to summarize, in terms of the approaches to management, initial management focuses on lifestyle modification with comprehensive lifestyle intervention. Then we move on to pharmacotherapy for those who have significant elevated BMI or associated pharmacological risk. And for those who have higher BMIs or for whom pharmacological treatment would be ineffective, then surgical treatment would be the best option. So that's where we are, and I thank you very much. We will stop right there.
Thank you very much, Professor Ferguson. Excellent. I will ask you to use 5 minutes of the question and answer to look at the drugs, because as physicians, we are definitely interested in those drugs that I asked you to skip over. I'm so sorry. But so one of the first question would be, tell us some more about the GLP-1's receptor drugs so that we can see how that works. I think we would definitely want some more information, but we are off schedule just now. So we have 15 minutes to the question and answer, and I'll ask you to use that 5 minutes to tell us about it. All right. Thank you for an excellent presentation. Question and answer will be at 4:40 p.m.
Okay, great.
All
Good.
right. Sam, can we have our sponsors' presentations, please?
Hi, Doc. Sure we can. It's our honor to introduce and welcome Mr. Paul Russell from Abbott Nutritional to give his presentation, followed by Mr. Dyer from Indos, who will also give his presentation, after which I'll have a video from the AGPJ and the CCFP, and then we go right into Prof. Tollereed. Well, introductions, of course, from our moderator, Dr. Williams Green. So first we welcome Paul Russell from Abbott. Are you there, sir? Saw you earlier.
Yeah, I'm here.
Okay, wonderful.
Let me share my screen. Are you seeing my Abbott slide?
Yes, sir, we are.
Okay. All right. Good afternoon. My name is Paul Russell from Abbott Nutrition, and I'm grateful for the opportunity to present on some of Abbott's products at this CCFP conference series. Before we look at some of these products, we need to assess. We need to assess whether your patients are getting enough adequate amounts of protein each day. Studies are showing or suggesting that we're not getting enough protein, and that approximately 42% of adults aged 51 years and over don't consume enough protein in their daily diets. Some protein sources are eggs, milk, poultry, and fish, which provide high quality proteins with all essential amino acids being present. Plant-based protein sources generally lack one or two amino acids. So therefore, we need to fill in the protein gaps with oral nutritional supplements. So we're going to start with Ensure Complete for patients who need to maintain and regain lean body mass and strength when recovering from illness, injury, or surgery. It has 30 grams of quality protein, 4 grams of fiber, 350 calories per serving, and it comes in assorted flavors. So for persons who need protein with less calories, whether they're going to the gym or replenishing depleted protein stores or just watching their weight, there is Ensure Max Protein Shake. It also has 30 grams of protein, of high quality protein. It has 4 grams of fiber with only 1 gram of sugar and is 150 calories per serving. Now, Ensure Max Protein comes in assorted flavors. For patients who want a vegan-friendly presentation, there is Ensure Plant-Based Protein Shake. It's dairy-free with 100% plant-based protein. It's 180 calories, 20 grams of protein, 5 grams of dietary fiber. And all our Ensures are gluten-free and suitable for lactose intolerance. So, recommend the right Ensure to help your patients reach their nutritional goals. For persons living with diabetes who require increased protein, we have a few presentations. Glucerna Hunger Smart has 180 calories, 15 grams of protein, 46 grams of fiber, and that's dependent on the flavor. It has Carb Steady, which is a blend of slow digesting carbohydrates, which is clinically shown to help manage blood sugar spikes. There's also a new presentation that's available called the Glucerna 1 gram Total Sugar Shake. It's 180 calories, it's 15 grams of protein, has 46 grams of fiber, again dependent on the flavor, and it comes in vanilla and chocolate shakes, and it's also carb steady. For even more protein requirements, there is Glucerna Protein Smart Shake. It's 150 calories, has 30 grams of protein, 4 grams of dietary fiber, and it comes in vanilla and chocolate flavors. And it's also carb steady. So all Glucernas are gluten-free and suitable for lactose intolerance. So we mentioned before about carb steady, and the carb steady blends of carbohydrates are slowly released into the small intestines and are later released into the bloodstream to help minimize blood sugar response. So recommend Glucerna products for your pre-diabetic or diabetic patients as part of their diabetic management plan. For wounds that are hard to heal, whether they're internal or external, could be as a result of diabetic wounds, pressure injuries, surgical incisions, or any other chronic wounds, there is Juven. Now, Juven is medical food in the form of a powder containing amino acids, arginine and glutamine, collagen peptides. It has HMB, which is a metabolite of leucine, and it has micronutrients, vitamins C, B, C, E, B12, and zinc. The combination of these ingredients support collagen formation in as little as 2 weeks. Just mix 1 sachet of Juven with 8 to 10 ounces of room temperature water or juice, and it comes in orange or fruit flavored. And my final product slide highlights the need for rehydration, certainly in this temperature that we're having here. Whether it's mild or moderate rehydration, there's Pedialyte. Whether we're exercising, we have extreme sweating, excessive sweating or extreme heat, or there's diarrhea or vomiting, Pedialyte provides hydration for all, not just for children. So I've included my contact information with my cell number, 489-6093, my email address, paul.russell with 1 L @abbott.com. And I want to thank you for having me, and please enjoy the rest of the conference.
Thank you, Paul Russell, and thank you for your information on the products. We look forward now to Indus Life Sciences.
Can I share my video?
Yes, you can. Please go ahead.
Yeah, thank you. Good evening, everybody.
Hi, good evening.
Second. Greetings, Doctor. Thanks for CCFP for this healthy aging and NCD chapter. Just from Indus Life Sciences, just like to refresh the brands that we have been detailing you. We have a nice protein supplement, and which you all know, as you could see in the screen, it's for the entire family, right from pediatric to geriatric. They'll benefit from this supplement, Amino Pep. You all know this is the first most comprehensive supplement. When I say comprehensive, Amino Pep is the only brand in whole Caribbean offers protein, vitamin, and mineral. When we talk about protein, as you could see in the screen, it has 10 essential amino acids, which you normally don't get in a regular diet. And these amino acids on active form for immediate protein synthesis. And amino pep also offers all vitamins, which is essential for all age group, especially for elderly people. It strengthens the energy, and it has zinc, which is also very vital for boosting the immunity at any age group, right from pediatric or even elderly people. It boosts the immunity for them. So amino pep gives a pep to the step. I'm not bashing other supplements. We all know that when we talk about supplements, most other brands, they talk about vitamins. And we are the first comprehensive formula in whole Caribbean, which offers not only the vitamins, plus essential amino acids for protein, plus zinc to boost the immunity. And it's 200 ml pack, cost around $1,800 to the patient. And also, I like to refresh about these indications, which normally we come across. Many times we have these conditions: heartburn, hyperacidity, gastritis, flatulence. We have a lot of antacids for this. But the highlighting point is that does every antacid offers the benefit? That's the biggest challenge. One antacid that can answer all these above indications is our new gel. The first antacid in Caribbean, again, comes with the alginic acid benefit. We know the benefit of alginic acid is it stops acid reflux and heartburn. So by forming the foam, as you could see in the screen, this alginate raft basically formed in just taking 4 minutes of this antacid new gel, and it prevents the stomach content moving from stomach into the esophagus. Thereby, it stops acid reflux, which we basically refer as GERD, and thereby it stops heartburn too. And as you could see in the video, this is how it blocks it. And this action continues literally for 5 hours. And then after 5 hours, what happens? This alginic acid raft is completely excreted along with stomach content. No residues left. So when the person is ready for next meal, the same action is repeated with new gel. So we have the extension of that. We all know that New Gelvo is also available, only one of its kind, a game changer antacid, I could say, which offers immediate relief from pain. Oxytocin is there, instantly reduces pain within less than 5 minutes. It's also referred as 5 minutes miracle antacid, New Gel O. Of course, we all know New Gel is safe in pediatrics as well as in pregnancy. New Gel O is not recommended in pregnant mothers and also kids less than 12 years of age. New Gel O is not recommended. But New Gel is very safe. And it has a range, as you could see here. It's available in sachets, again, one of its kind in Caribbean. I have not come across any liquid antacid in a sachet formulation. And we know New Gel. Longer than that late-night snack. New Gel is acidity. It lasts 5 minutes. Give me New Gel antacid. Quick and fast. New Gel antacid is sugar-free, safe for all, and the only antacid with liquid on the go sachets. New Gel antacid. Quick and fast, relief that lasts. Yes, it's quick and fast and relieves, instantly. And Doctor, one other brand I like to share is that we are the first company has dropped down the price of this brand, and the Neurabalin, that's our pregabalin. Just few months ago, around 3 months ago, we dropped down the price. Thereby, Neurabalin is fully subsidized by NHF. So if you think of prescribing pregabalin, please think of Neurabalin. Your patient is going to save huge amount every time they fill the prescription. So that's our Neurabalin. And the last brand I like to refresh today, because the FIFA is going around. The FIFA has kicked off. Our ready spray is available for sprain, strain, all those conditions, especially people love football. is very ideal. Even children, it can be recommended because you could see the ingredients, they're all organic. The plant extracts, I mean, eucalyptus, turpentine, menthol, like that. So even pregnant mothers, I come across some of gynecologists told me that during pregnancy, induced back pain, this could be recommended as a spray. So of course, it has no chemicals on it. That's why it is recommended. Many schools also now reaches for the sports day for this ready spray, pain spray, and it's over the counter here. And we have 43 ml container, just cost around $300, and the bigger version is around $700. And it's listed on OTC. That means you can pick up from the shelf. Ready spray, as we communicate it as powerful like a real beer, safe like a teddy bear. That's our ready spray. Let's feel the beat of the football FIFA 2026. Okay, with ready spray. Thank you very much and enjoy rest of the presentation.
Thank you, Indus. And Sam, the next presentation.
Yes, Doc. Going to have a video presentation now.
Every day, physicians care for the health and well-being of others. They guide patients through illness, uncertainty, recovery, and hope. But amid the demands of medicine, an important question remains: who cares for the doctor? The Association of General Practitioners of Jamaica, in collaboration with Medimpex Jamaica, invites you to attend the annual Mental Health and Ethics Webinar 2026. Join consultant psychiatrist Dr. Chevelle Westcar for an insightful presentation entitled "Who Cares for the Doctor? The Emotional Journey of the Physician Across the Career Lifespan." Explore professional identity, resilience, well-being, burnout prevention, purpose, fulfillment, mentorship, and maintaining balance throughout a medical career. Then join Dr. Alveston Bailey, CD, General Practitioner and Public Health Specialist, for the ethics session. The Ethical Physician, featuring the presentation Ethical Practice Across the Career Lifespan, Maintaining Competence, Purpose and Professional Responsibility. Discover how lifelong competence, professional responsibility, patient safety, mentorship and stewardship shape ethical medical practice throughout every stage of a physician's career. Participants will also benefit from special educational presentations from Medimpex, our sponsor of this event, on their wide range of pharmacological products aimed at optimizing pharmacotherapy in mental health and other product lines offered by Medimpex Jamaica. Attendance is absolutely free. Participants may earn 3.0 CME credits, including 1.5 mental health credits and 1.5 ethics credits, and the CME certificate is free. Simply attend the webinar and successfully complete the post-test assessment on the MedPulse Caribbean e-learning platform. Whether you are an intern, resident, early career physician, family physician, general practitioner, consultant, or senior practitioner, this webinar has been designed for you, because caring for physicians is essential to caring for patients. Register today. Registration link available through AGPJ Secretariat. Telephone the Secretariat at 876-517-6636 and 876-595-0928. Email the Secretariat at agpjamaica@gmail.com and agpjsecretary@gmail.com. We look forward to welcoming you.
Thank you so much. And we encourage you to attend the seminar on, encourage you to attend the seminar by the AGP. So I'm hoping everybody is getting ready because we're going to introduce Professor Marshall Toller Reed. He also has a lot of letters from the alphabet. Of course, he's a physician and endocrinologist and the current director of the Caribbean Institute for Health Research Care at the University of the West Indies. He's a graduate of the university's MBBS program and attained his MPhil in epidemiology from the University of Cambridge in 1997 and the DSc in epidemiology from the Netherlands Institute for Health Sciences in 2003. He pursued training in internal medicine at the Howard University Hospital in Washington, D.C., and subsequently joined the National Institutes of Health Inter-Institute Endocrinology Training Program in 2000. And he was stationed at that time in Maryland. Subsequently, he went to Phoenix, Arizona, so he knows the U.S. quite a bit. Dr. Toller Reed was certified by the American Board of Internal Medicine in Internal Medicine 2000, and he became a fellow of the American College of Endocrinology 5 years later. So Professor Toller Reed joined CARE in 2003, and as you have heard, he's now the head of CARE, he's now the director since 2020. He has published widely in the areas of obesity, diabetes, cardiovascular disease, and prostate cancer. So we look forward to hearing his presentation. Now, go ahead, please.
Yes, thank you very much, Dr. Williams Green. And I'm mindful of the time. So let me see if I can pull this thing out of here so I can get the presentation going. Okay, so this floating bar is, I'm putting it at the bottom. Hopefully it will stay there and not interfere with what you have to talk about. I wasn't quite
Professor,
sure how
we're
to
actually still
approach.
seeing the
Okay,
blocks.
you
I
still see the
apologize.
floating bar.
Is
Okay,
there a
I don't
chat
know.
that's open as well?
I don't have a chat open, but let me see hide floating bar meeting controls. Does that make any difference?
No, still
Okay, I'm not
that
seeing it.
that one's a little bit better, but there's still a little section of it that
Okay,
has it.
okay.
All right, let's try. Let's go through
Yes,
the
let's hope it
presentation.
won't interfere too much. All right. So I wasn't quite sure how to handle this topic because it's quite broad, but I thought I would just focus on two conditions that we see every day, one of which has become more important to me because of the work I'm doing now on one of the projects which I'll tell you about in the course of the um, presentation. So we'll just talk a little bit about some situations where incorrect measurement or poor choice of tests could result in overdiagnosis and not necessary treatment. And I'm going to focus on diabetes, talking about some of the tests that we have for diagnosis and how some of these tests may affect whether we classify somebody as having diabetes or not, and where some tests may or may not be appropriate. And I'm also going to talk about the same issues around hypertension because there's more than one way to make a diagnosis of hypertension. And I'll focus a lot on blood pressure measurement, which is the area I'm talking about, which has become quite a passion of mine. Just really to make sure that you're aware of how poor measurement technique can result in incorrect measurements and inappropriate treatments, and also some situations which may not only be related to measurement, which can result in overdiagnosis and treatment. So one of the things that we're dealing with is really the increase in the non-communicable diseases, and diabetes and hypertension are really major contributors. This is PAHO's 2025 report, NCDs at a glance. And here you see what is happening in terms of where countries are going in terms of the progress towards reducing premature mortality from NCDs. And then you can see some which are making progress, those in the Blue are on target, those who in the orange are on their way to target, and those who are in the pink, among which you'll see certain countries are actually regressing, meaning that we're moving away from where it is. So we know we need to identify these conditions quickly and address them so that persons don't have unfortunate outcomes from them. This is the same slide that Professor Ferguson presented, not as dramatic as his, but you can look at his when you have a chance. But it really shows why we have a lot of NCDs. It's driven primarily by obesity and the new understanding of the cardio kidney metabolic syndrome is really that obesity is the first step in a number of metabolic abnormalities that result in heart disease, cardiometabolic disease, diabetes, as well as kidney disease. So here we see the prevalence of obesity, not overweight, obesity in the Jamaican population. And you wouldn't be surprised when we say that the median BMI for Jamaican women is 50%, meaning that 50% of our female population is in the obese category. Not as high for men. And of course, you saw the highest levels in persons 35 to 74 and lower prevalence, probably related to a survival effect in those who are in the elderly groups. And of course, a pattern of diabetes will follow that same picture because most of our diabetes is type 2 diabetes. And so we tend to see a female predominance of diabetes across all of the age categories. We know too that for the region, Jamaica is actually leading in terms of diabetes death rates for the region. And this is based on mortality data. And you can compare Jamaica against some of the other countries, demonstrating a couple of the sex differences that you can see. If you want to look at this report, the reference will be there at the end. And from our data up to 2017, we see that the prevalence of all these risk factors is increasing. So it means that with obesity increasing and these NCDs increasing, we really need to be able to diagnose and recognize when these are present very quickly. So I'll talk a little bit about one of the cases, and I think this one may kind of help to bring together a number of the issues that are relating now to diabetes specifically. So this was a 6-year-old business executive who did his annual panel as part of his checks. He wasn't ill, wasn't on any medications, just his supplements. Blood pressure is good. He's overweight, and he did his labs. He has a normal fasting glucose, an HbA1c of 6.9%, and also a low HDL cholesterol. The other triglycerides are okay. So this looks like somebody who could have metabolic syndrome and so therefore would be at high risk for having type 2 diabetes. But I don't know. Do you think this person has diabetes based on the lab results? What are the things that you're seeing here that might make you a little bit concerned? So you have here one test. So those who are not used to the millimoles, in milligrams of 5.3 might be about 90 milligrams per deciliter. And then an HDL of 1 might be around 30 milligrams per deciliter. So we can see there's a little bit of a mismatch between the fasting glucose and the A1C, because this A1C would suggest one thing, but the fasting glucose is suggesting something else. So what's going on? What's going on with this patient? This is not uncommon. I'm just going to talk a little bit about how we came to diagnose diabetes because the history is important as it's been evolving over the years. And for many years, we actually had no standard way of diagnosing diabetes. It wasn't until 1985 when the World Health Organization made a decision to make an official way of diagnosing the condition. And at that time, they used two criteria, a fasting glucose of 7.8 and a total glucose of more than 11. And there are a number of factors that went into this decision, but I think one of the things is also some of the data that they had. The oral glucose tolerance test was the preferred method. And it's important to remember that there are some caveats when we're doing our oral glucose tolerance test because physical activity and eating will impact the results of the oral glucose tolerance test. And so patients who restrict their carbohydrates close to the time of the testing or engage in heavy physical activity prior to the test can actually end up having results which are not abnormal, even though we know based on their glucose testing or other tests, they are likely to have diabetes. So you can fool the test. It's important to think about the food and activities, smoking, particularly in going for the test. And I think this is an important one because a lot of patients, because the glucose tolerance test is very long, will come in, go on the road, come back in 2 hours. But the idea is that person should remain wherever the test is being done for the 1, 2 hours. 2 hours is standard, or 3 hours if that's what you're doing, to complete the test rather than have them doing excessive physical activity. So the data that kind of suggested that maybe this glucose tolerance test with readings over what 11.1 is the standard is really coming out of the study of the Pima Indians in Arizona. So that was a study done in the 1960s in which they were exploring issues around arthritis. But they discovered that there was a lot of diabetes in the population. And so on that particular reservation, everyone over the age of 5 was invited for a glucose tolerance test. And this is what they discovered when they looked at the distribution of the blood glucose. These are the data for men. And what you can see here is that as you get into the old age group, 35 and over, there seem to be 2 peaks. So there's one distribution of blood sugar and then a second blood sugar distribution. And where these two distributions are meeting is just about where the cut point for diabetes was used. And this is really one of the strong pieces of evidence for them to use the 2 hour of 11.1 or 200 milligrams per deciliter as a cut point, because it was not just in men. This is the same slide for the female population. And again, you can see this kind of bimodal distribution, which is emerging over time as the population ages. But there was a problem because the oral glucose tolerance test was probably taking too long to perform, and there are other issues around the accuracy of the test. And so in 1997, the American Diabetes Association made a decision that it would move away from just doing the glucose tolerance test to actually just using fasting blood sugars alone as one way in which a diagnosis of diabetes can be made. And so in 1997, nearly 10 years later, this is the new criteria which came out. So you could, instead of doing a full glucose tolerance test, just do a fasting blood sugar, meaning no eating for 8 hours prior to the testing. And if you had a fasting glucose over 7, that could also be used for diagnosis of diabetes, as well as the conventional criteria, which is the oral glucose tolerance test with values over 11.1 or higher as being diagnostic. Of course, for persons with symptoms of diabetes, a reading over 11.1 was considered diagnostic. For asymptomatic patients in whom the fasting and the 2 hour readings were being done, these would have to repeat it on another day to confirm the diagnosis. It wasn't just based on one abnormal glucose. And the reason why they felt comfortable using the fasting glucose was based on data like these. I'm just presenting here data coming from the Pima Indian population. And what they did was look at a specific complication of diabetes, which was retinopathy. They looked at it in a number of populations. There was the NHANES sample as well as the Egyptian eye study, and the Pima Indian population also had retinal photographs done. And what they were able to show from these data is that a fasting blood sugar of about 7 or 126 is what we use as our cut point, milligrams per deciliter, was where you saw a significant increment in the prevalence of diabetic retinopathy. So diabetic retinopathy on fundoscopy is very specific. So it's unlike renal disease, which could be due to other complications. Retinal disease can be specifically attributed to diabetes. And this also corresponded to where the 2 hour glucose was around 200 or 11.1. So they felt comfortable that the fasting blood glucose could be used as an alternative to the glucose tolerance test. So they kept the 2-hour glucose because a lot of the data we had around diabetes was based on a diagnosis from the 2-hour glucose. And the data we showed earlier with the bimodal distribution, showing that there seem to be two populations. And of course, the evidence that I just showed a while ago that there's a higher risk of microvascular complications, specifically retinal disease once the blood sugars are above that region. But they felt it was time for a change because there's a lot more diabetes, just like what we're seeing here. And there was a need to make the diagnosis a lot easier and faster and less costly. And so delaying testing for people to come in for a formal glucose tolerance test, maybe having to take the day off, and also the cost of the time as well as the other resources that are needed was one of the things that pushed them to use the fasting glucose a lot more. They also discovered that there are a lot of challenges with the way in which the glucose tolerance test was being performed in practice. And so because of those errors, holding out to do a glucose tolerance test just to prove somebody had diabetes was really not that effective. They also had noticed that there's a lot of variability in the glucose tolerance test. And again, as we showed in the previous slide, there is an increased prevalence of microvascular disease with a higher fasting glucose. So now in 1997, the fasting glucose would be an alternative to a full glucose tolerance test. In 1999, the WHO made a bit of a compromise by lowering their 7.8 to 7 as a fasting glucose, but they still require the glucose tolerance test. And so sometimes you'll see where there are differences in diabetes prevalence because once the issue of using fasting glucose instead of the 2-hour glucose became prevalent, they began to recognize that there were some patients who would have a normal fasting glucose, but others that would have an abnormal 2-hour glucose, and there would be some who are missed. And so one of the things that they began to recognize is that there are some patients who may be more likely to have a high 2-hour glucose but a normal fasting glucose. And this may be related to the pathophysiology of diabetes, whether it is primarily related to insulin resistance or whether it is a result of impaired beta cell function, which may be more common in some settings. So elderly patients and Asian populations were more likely to have normal fasting glucose readings. But if you were to go to do the full glucose tolerance test, you'd identify that they actually do have some dysglycemia with elevated 2-hour readings. And here in Jamaica, this is a paper by Sargent and Boyne, where they looked at Spanish patients from Spanish Town, and they were able to show that older persons, women, those who are more obese or had higher blood pressure, were more likely to be missed to have to miss recognizing an elevated 2-hour glucose if we're only basing our decisions on the fasting glucose. Since that time, we've gone further because moving from just the full glucose tolerance test to the fasting glucose to now the use of the A1C, which is, we know, an integrated measure of glucose control over a longer period, is now something else which has come on the table. And so in 2010, the American Diabetes Association felt that enough had been done to make the HbA1c an alternative means of diagnosing diabetes. So you don't have to just do a fasting or to do the full glucose tolerance test. There's the option of the A1c. But there are some caveats that we have to bear in mind. The reasons why they felt it was time to include A1C was because there are errors with a lot of the glucose measurements. People may not recognize it, that even though you do the fasting or whatever glucose measurement in the fluoridated tube, the tubes should really be put on ice once they're collected, because even with fluoridation, there's continued metabolism of glucose. And so the plasma measurements will still come up lower the longer the sample has been left standing at room temperature, despite the tube. The A1C had a lot of advantages because you can do it at any time. The A1C measurements are more stable at room temperature. There's going to be less day-to-day variability in the reading. And since the 1997 criteria were first produced, the international laboratories and experts have been working consistently to create a more standardized assay, which would allow you to get the similar reading at different labs. And so at that point, American Diabetes Association said an A1C of 6.5% or higher was appropriate. There were some concerns. I think the biggest one has been cost because the A1C test is a lot more expensive. The method that is to be used, and please pay attention to this, the HPLC or high pressure lipid chromatography is actually the ideal method for measuring A1Cs. There's actually only one lab that I've seen doing HPLC currently as the way of measuring A1C. The HPLC has a couple of advantages because it can identify things like hemoglobinopathies, which would alert the clinician about the possibility of abnormal results from things like sickle cell trait or abnormal hemoglobins, which can affect it. You can have the possibility of some false results, especially when there's iron deficiency, with transfusions, with hemolytic diseases, not just sickle cell, but things like malaria, and of course, acute blood loss with transfusion, meaning that A1C may no longer reflect 3-month experience. We also know that there are increases in A1C with age, which take place naturally and may not be indicative of dysglycemia. So the challenge is really around the standardized assay. So it's not just a method, but there is a way in which the laboratory will standardize the measurement. And this is using a standard sample that is used internationally to confirm that the readings that are obtained are consistent with that. This is really one of the slides which actually shows us a little bit of the conundrum that we have. This is put out from the NHANES study, National Health and Nutrition Examination Survey, which is done periodically in the US. And at that time, they were able to look at the 3 methods among some of their participants that could be used for the diagnosis of diabetes. Please pay attention to a couple of things. Depending on the test that you use, the prevalence of diabetes will be different. So if you look at the blue circle, that is showing you the prevalence of diabetes based on a total glucose, and they found that this was 4.9%. If you look at the green circle, that is the prevalence of diabetes based on fasting glucose, and this was actually 2.5%, much lower. And if you look at the orange circle, the prevalence of diabetes based on A1C is actually 1.6%. So you'll see that each of the methods will actually give you differing estimates. And when you look at the number of persons or where there's consistency for all 3 tests, meaning that the person meets the criteria for diabetes based on the fasting glucose, the total glucose, and an A1C, that's only taking place in 1.2% of the population. So it's very important to know that each of these tests may actually be detecting slightly different populations, even though they're all being labeled as diabetes. So you have to be careful which one you're choosing and to kind of think around which one may or may not be appropriate so you don't overdiagnose your patients. This is the last set of slides around diabetes diagnosis I'm going to show. This is actually an interesting study where they pull a number of data from various cohorts where they were looking at patients with sickle cell trait as well as patients who didn't have sickle cell trait. And what they had shown was that even though when you looked at their blood sugars, the prevalence of diabetes and prediabetes was the same, for persons with the trait, you're actually seeing a lot lower prevalence of diabetes and prediabetes if you use the A1C for diagnosis. So just something to bear in mind. And this is just kind of showing that when you're looking at the A1C, the straight line is the accuracy of the test, the A1C, compared to fasting glucose for persons with the sickle cell trait versus the bolder blue line, those without the trait. And you can see that this curve, the higher the curve or the closer it is to the 1 and the top of the curve, the better the test is. And what you're seeing here is that it's underperforming, the A1C is underperforming, even in persons who have a trait, not persons with the sickle cell disease itself. And that when it looks at diabetes based on total glucose, the trait is really patients with the sickle cell trait, their ability of the A1C to detect diabetes is really not much better than tossing a coin, meaning that it doesn't perform very well. So these are some important considerations for our setting. So this is what happened to the patient. He did a 75-gram glucose tolerance test, and these are his results. Does he have diabetes based on these readings? That's for you to think about in the question and answer because there's no
No.
time. No, he doesn't meet the criteria. So actually, this is interesting. So I had asked him to do another A1C at a lab that uses the HPLC method, and then also it would detect if he has hemoglobinopathies, which may have affected his A1C result because the glucose readings are okay, but the A1C is out. So in those situations, think about moving towards a formal glucose tolerance test, and then also think about factors that may interfere with your A1C result and give you inaccurate results. My second case is going to be an intro to hypertension. And this was a 55-year-old patient with Graves' disease. I hadn't seen for over 10 years, but she turned up because she was trying to get surgery done and she needed clearance. And since I had seen her many years ago, she had been told that she had borderline hypertension and that her blood sugar was high, so she was put on metformin. So when I saw her in office, her blood pressure was elevated, 143/75. Pulse was okay. She had a goiter, but nothing else that was really significant. And of course, she's quite obese from her BMI. So her labs were this. She had an A1C done, which is what was used as the basis for the diagnosis of diabetes of 6.5%. But at the same time, what you'll notice is that her thyroid levels are out of control. So she has a very low TSH, elevated free T3 and free T4. So if you got this patient, would you believe that this patient has diabetes based on the labs as presented here? And not just diabetes, would you also classify this person as having hypertension? Think about it. So hypertension is quite common in our setting. We can see that the prevalence increases to almost everybody over 75. You're looking at almost 3/4 of the population having hypertension once you get into the 60s. So it's a very common condition. And one of the things, because it's so common, means that we're dealing with it every day. And we have to be sure about how we're diagnosing it and also what we're using as our parameters to make medication adjustments, because we know that the lower the blood pressure is, the lower the likelihood of complications from hypertension. And what you can see here for Jamaica is that apart from Haiti, we're like at the top there for cardiovascular mortality in the region. So hypertension is really a big contributor to that. And one of the projects we've been working on is this project called CATCH, Caribbean and South America Team-Based Strategy to Control Hypertension, which is really all around strategies to get blood pressure under control. Because what we had realized was that there were a lot of patients with uncontrolled hypertension, even though a lot of the persons were diagnosed and had been to the doctor, the levels of control among those under care was poor. And so really that's what CATCH was aiming to work on, to reduce the disparities between patients with diagnosed hypertension and with adequate blood pressure control. So we went about this quite enthusiastically, and we went into the clinics looking for patients with uncontrolled hypertension who we were going to be recruiting into our study, because that's what we're going to be addressing. And of course, we went in with the research assistants. We were using the results that are coming from the chart. And after a while, everybody that was coming up with high blood pressure from the measurements, when we did it with a standard approach, had really well controlled blood pressure. And so we spent quite a few months trying to find patients with uncontrolled hypertension to the point where we had to abandon the use of the records or the measurements that were being done in the clinic because we recognized there was a lot of inaccuracy in terms of the readings. And so CATCH really highlighted for us the need to work or focus a lot more on improving the ways in which we're measuring blood pressure in our clinical settings. So we know that blood pressure assessment requires three things. It requires an accurate device. It also requires that the setting be correct and that the technique for the measurement of the blood pressure is appropriate. And a lot of times in our settings, this may not be the case. There's a lot of belief in the auscultation as the best means of measuring blood pressure. But we're moving away from that because the auscultation has a lot of issues. One of them, of course, being the use of mercury for the thermometers and the toxins that can produce. A lot of times the devices are not being calibrated, even though they're using auscultatory measure methods in clinical practice. And there's a lot of observer error, which is related both to issues of vision and hearing and also issues of digital preference. So we've moved away to automated blood pressure monitoring, and this really uses the arterial flow to assess what the systolic and diastolic blood pressure is as opposed to the cough sounds, which we've been accustomed to. And it has a number of advantages because of its portability, ease of use, the fact that other members of the team besides trained clinical staff can do the measures is very helpful for screening, and it has been used in home blood pressure devices. And so it really moves the measurement of blood pressure in a way that it doesn't require as much effort on our part to get accurate readings. Of course, if you're using something that requires electricity or batteries, that may be a limitation. You have to be sure you're using an accurate device. And there are ways in which you can determine which devices are accurate. There are lists that are available, as well as ways in which you can validate the use of these machines before they're implemented. It depends on the accuracy of things like your cuff and the tubing, because a lot of times, as we discovered, if it's not properly cared for, then the accuracy of the machine goes down. And of course, when patients have arrhythmias like AFib, these measurements may not be possible. So the main things are really around reinforcing some things which are critical for the measurement of blood pressure. The patient should not need to use the bathroom. They should not have consumed coffee, alcohol, or not exercise for 30 minutes before the blood pressure measurement. The patient should be given a chance to relax sitting on the chair, usually for up to 5 minutes, although there are protocols that say at least 2 minutes of rest. There should be no talking either by the patient or the staff member, reading or use of electronic devices in this rest period or during the blood pressure measurement. This is ideally how the patient should be positioned. This is a slide from PAHO. So no talking, the arm should be supported. Ideally, blood pressure should be measured on the bare arm, not through clothes. The feet should be flat on the floor and supported. The cuff should be at heart level. The legs should be uncrossed. The patient should not have to be urinating, and they should have good back support. And why all of these things are important is because there are significant differences in blood pressure, which can be attributed to issues related to all of these factors. So here you see the effect of talking, poor positioning of the legs, use of an unsupported arm, poor positioning of the cuff, needing to use the bathroom, consuming coffee or smoking, or an inappropriately sized cuff. These are all important things that can raise blood pressure measurements. Usually at the first visit, we try to do blood pressure in two arms because if there's a big difference, maybe there's an arm that needs some attention or some underlying arterial disease. And the important things as well is that two measurements are done, not just one, separated by at least 1 to 2 minutes to determine what the blood pressure should be. Electronic blood pressure monitors may automatically display the blood pressure value, and some of them may actually give you an average of the readings. It's important when you're doing the blood pressure to make note of a couple of things, whether the patient is sitting, lying, or standing, which arm is being used, for the blood pressure measurement, the cuff size, which is important, so that cuff should be used going forward for that patient, and also any issues around the patient's attitude. If your machine doesn't average your blood pressure, then you will have to do the two measurements and do the average. You should give the patient the blood pressure readings. This is just part of their regular care, and whether this is suggestive of normal blood pressure or abnormal blood pressures. So a couple of things are important in the clinical setting, that even though the blood pressure, the automated device is preferred, you may still need to use your auscultatory sphygmomanometers from time to time, and you should have at least one person who is familiar with the process. And then there is the certification process, because what we've come to recognize is that we all assume that we do blood pressure properly, but there are standard ways in which to do it. POW actually has a free online course that is available on the website, and Trevor was one of the first people to do it again just before he did his Ministry of Health presentation. So I'm just displaying his certificate. So this is something that you can do as well if you want to have that done. So last bits are really just about how we're diagnosing, and I'm going to make reference to the latest guidelines for hypertension and that Professor Ferguson was involved in terms of how do we determine whether we're dealing with somebody with hypertension. Just the same way we spoke about the diabetes issue and the multiple methods, we also have multiple methods for hypertension diagnosis. Traditionally, we have used blood pressures over 140 and 90 on 2 occasions in the clinic, at least 4 to 6 weeks apart, ideally within 4 weeks, but not more than 6 weeks, to confirm that the blood pressure is consistently elevated. Again, the positioning and the measurement are critical, because very often if the technique is poor, then we get higher blood pressure readings in our office setting. And ideally, it would be good to do this unattended. So a lot of times we do the blood pressure with the patient sitting in front of us. That's really not ideal, or even the nurse or other staff members. Where you have the automated devices, the devices can be set to do the countdown for the patient to the timing of the blood pressure, and it can do the average reading. So you leave the patient and come back, and the result is on display for the device. But if you do elevated blood pressure readings, what the new guidelines suggest is that we should try and do ambulatory blood pressure measurements. This is an example of the system where a cuff is placed on the arm, connected to a monitor. The ambulatory blood pressure has a lot of advantages. It gives us an average of the blood pressure over a 24-hour period. And so in cases where there's white coat hypertension, which may delay diagnosis, we can be more sure that the blood pressure is consistently elevated. It can also pick up blood pressure patterns. So one of the things that we very often miss is the non-dipping blood pressure pattern. So blood pressure should go down when you're sleeping, and if it's not going down, there is a problem, because those patients are at higher risk for complications like stroke and heart disease than patients who have a dipping pattern. And of course, a 24-hour value of more than 130 for systolic blood pressure or 80 for the diastolic is used for our diagnosis. The alternative to the office or the ambulatory is to do the home blood pressure measurements. This is especially helpful where you have limited access to resources and when there's high white coat hypertension. Usually we will look at an average systolic blood pressure at home more than 135 or diastolic of more than 85. And so I'm going to ask you to show this video, even though we're running out of time, a 2-minute video just reinforcing how blood pressure should be done at home. So over to our team for this video.
Okay, let's have a real talk about blood pressure. Do you monitor yours regularly? It's something everyone with high blood pressure should do, but it's something most people don't know how to do correctly. Checking your blood pressure regularly will help let you know if you have it under control. It will also help you start to understand which factors are putting you at high risk for stroke and heart attack. Before I get to that though, I just want to stress one thing. If you have high blood pressure, you should talk to your doctor to figure out how frequently you should be checking it at home. For most people, taking your blood pressure twice in the morning and twice in the evening, even just for a week, will help you and your doctor get a better understanding of your blood pressure. For morning readings, it's best to take those before you take your blood pressure medication. It's also very important to avoid exercise, caffeine, or tobacco at least 30 minutes prior to testing, since those can affect your levels. Now, let's move on to talk about the proper way to measure your blood pressure at home. Nearly half adults in the U.S. have high blood pressure and are at high risk for stroke and heart attack. So self-measuring is one of the easiest ways to be proactive about our health. Here I have my blood pressure monitoring device. It's easy to use and it helps me get an accurate reading. Be sure to get an automated device with the upper arm cuff. That's the type doctors recommend. The first thing you want to do is find a quiet place to sit where your back is in an upright, stable position. A dining room chair is great. You want to make sure the chair isn't too soft so your body is fully supported. Sit with your feet flat on the floor and don't cross your legs or ankles. If you need to use the bathroom, make sure you go before you do your reading. Next, rest your arm on a flat surface with your palm facing up. Place the blood pressure cuff on your bare upper arm just above your elbow. Your arm should be relaxed and resting so the cuff is at the same height as your heart. Now rest quietly for 5 minutes before taking the first measurement. Avoid talking while taking your blood pressure measurement. Once your first measurement is completed, write down the blood pressure numbers and pulse that are displayed on the device. Wait 1 minute and then repeat this process again. As you just saw, it's important to check your two measurements at around the same time each morning and evening. At your next doctor's visit, be sure to share your blood pressure numbers so you can discuss the numbers and so your care plan can be changed if necessary. That's it. Not bad, right? Measuring your blood pressure at home is easy to do and a great way to stay on top of your health. If you have more questions about managing or measuring your blood pressure overall, visit the website.
All right. Okay. All right. So that's a resource I often share with patients. And then this is a recording that I just pulled this from the American Heart Association website. So the importance of the measurement and using the home measurements is especially important when we're making decisions around therapeutic changes. And so that's actually one of the things that is part of the CATCH project, which is where we're encouraging patients to do these home blood pressure measurements and for the physicians to also utilize this as one other means of making a decision around whether there's really need for a therapeutic change. So what happens a lot of times is that patients are overtreated or they're put on multiple medications when in fact they could be undertreated if the use of these logs at home were there. And it just has simple instructions. Usually they try to do this for a week or 3 days over a week before coming to the visit. His instructions on doing the measurements, reminding them to take 2 readings when they should do these readings, and bringing them back to the office can make a difference in terms of treatment. So this is our case. So what do you think about this patient? Does she have diabetes or hypertension? This is really one of the things that we want to think around. And for this lady, I actually don't know. And I'll say that because she was hyperthyroid. So it's in addition to all the things we spoke about, the fact that she had uncontrolled thyroid disease would result in elevated blood pressure and also elevated glucose readings. And so what I have said is that we will recheck these things once she's euthyroid again. So those are my references, and thanks very much for your attention.
Thank you so very much, Professor Marshall Tollery. We really have had a wonderful survey from your presentation, and I'm sure there'll be lots of questions. But I did want to give Professor Trevor just a few minutes to get into the pharmacotherapy for the diabetes. For obesity, because a lot of us are interested in this. And then we will put in our questions. I am looking for a Q&A. Sam, is there a Q&A? Because I'm not sure. If
There's
it
a
is so,
Q&A, doc, but I'm not seeing any questions just yet.
all right. So please put your questions in. But Professor Trevor Ferguson, we really want to hear about the receptors. And we really have been honored to have such high level prominent persons in this area. They are both very modest and they don't blow their own trumpet, but we can be very proud. It's almost as if we had Usain Bolt running for us here. We had Professor Trevor Ferguson and
Not tall like you said, both. That is just Sappho. Professor Sappho is just short. And I'm from Trelawney.
from Trelawney. That's right. Prof, that one, that one really amused you. Happy to hear that. Okay, but we really have such prominent persons, highly peer-reviewed papers. We have such distinguished persons with us, endocrinologists, epidemiologists. So, is Prof. Ferguson still around?
Yes, I am.
Okay, great. Because I'm really interested in the drugs, and I didn't want you to fly through it. So that's why I wanted to give you a little time.
All
So
right,
please
so
go
let me
ahead.
just probably take a couple of minutes and go through these two. Da, 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 da. All right, so let's see where we are. Trying to get this to do the right thing. All right, so we did mention the overall FDA approved drugs. Orlistat is still available locally and is one that can produce anywhere between 3 to 5% weight loss, has significant um, metabolic benefits. So it is something that I think should be considered for patients who are able to tolerate. I've used it in some patients with varying results. The probably patients have not been as enthused as I am. So we will see. But it's an old drug available since 1999. So 3.1% reduction in weight loss. 70% of participants achieve greater than 5%, which is the initial target that we're looking for. Additionally, systolic blood pressure reduction, LDL blood pressure reduction. The main drawback really is the side effect profile, which include GI side effects, oily fecal spotting if is used with a fatty meal, fecal urgency, steatorrhea. These tend to settle after initial use, and if we avoid people to avoid high-fat meals while they're on orlistat, and of course should have vitamin supplementation as well in terms of to ensure that they're not missing out on critical vitamins. So it's an agent that is available, can be used, much less costly than our GLP-1s. So the GLP-1 is the main driving force for obesity management now, and recently was added to the WHO VEN list. Currently not in the regular pharmaceutical system in Jamaica, but several practitioners are importing these and have been using them. And I know at least one pharmacological company is in the advanced stage of bringing the agents in. And also just to mention that the Ministry of Health has commissioned guidelines on the management of obesity. So within the next 6 months to a year, we should have official documentation as the recommendations. So these have multiple effects on the liver, reducing gluconeogenesis, decreasing steatosis, intestine, increased gastric emptying, decreased GI motility, in the brain, decreased food intake, decreased reward, and decreased palatability. It does cause some increase in insulin sensitivity and glucose uptake, increases pancreatic insulin secretion, increases insulin synthesis, decreased glucagon, decreased apoptosis, and increased beta cell survival. So overall favorable profile from the metabolic area. The two main agents currently
recommended are semaglutide and tirzepatide. So semaglutide was approved for weight management in 2021 and in adults and 2022 in children. The trade name is Wegovy for obesity. Ozempic is a brand for diabetes. And recently, there's also oral semaglutide that's available in the US. I'm not sure when that will get to Jamaica. Their studies have shown significant reduction in major acute coronary events, as well as cardiovascular events, rather, in patients which established CVD and obesity. One meta-analysis showed an 11.4% reduction in weight loss compared to placebo. Over 85% of patients will achieve greater than 5% weight loss. And overall, we're looking for about a 16.1% reduction in weight loss, reduces waist circumference, reduces blood pressure. I think I don't want to take up all the time, so let me go to tirzepatide. This one has a dual glucagon-like peptide and GIP agonist properties, was approved in 2023. The trade name is Zepbound, and for diabetes, the trade name is Monjuro. Leads to a 50 milligram dose results in a 12.4 reduction in weight loss. In the Surmount trials, weight loss ranged from 11% to 21%, and 90% of patients achieved greater than 5% weight loss. So very, very effective. Also reduce waist circumference by 19%, decrease systolic blood pressure by 8%, reduce LDL by 9%. Mean A1C decreased by 2.1% among persons with diabetes. The adverse effects, of course, GI in particular, nausea, diarrhea, constipation, vomiting, and as we mentioned earlier, is contraindicated in patients with medullary thyroid cancer, pancreatitis, men too, cautious use in chronic kidney disease, and those with GI motility disorders. So those are the two agents. I expect that in the next few months, we should have them more widely available. We will also have the Ministry of Health guidelines to support the use of these medications. So overall, I think we should have clearer information. There may need to be specific training in the administration of these drugs and for side effects, etc., so that they can be safely used and for the right indications. So I'll stop there, and I guess we can take questions.
Excellent. Thank you so much. And very good news as well about the drugs coming here. I'm waiting for questions, but let me just ask one as moderator privilege. With regards to the drugs, will they be coming within, you mentioned a company bringing it in, but with the government, the Ministry of Health also bring it in so that it will have NHF coverage?
So, well, the Guideline Development Committee just started meeting like a month ago. So that process will take several months. So what will happen is that based on the review of the data and the practical application, so if it is recommended, if it's recommended by the Ministry of Health, then quite likely there would be NHF support as a second step. But the first thing would be for the Guideline Development Committee to review. Of course, I think one thing in the favor is that the WHO has recommended that the GLP-1s be included in the VEN list. So it's becoming part of the standard of care. So it is likely that based on the evidence that the Ministry of Health guidelines will recommend it. But of course, we do not know as yet because we have to do all the review. and look at the practical applications within the local context, and then to see where that goes. So it's a process, but given the challenges with obesity management, I think this is an important step. I think, though, that for organizations, we have to continue to emphasize the social and commercial determinants because while I think pharmacological therapy is critical and important, if we don't address the upstream determinants, we're kind of going down a slippery slope so that everybody become patients and everybody be on medication rather than we have a more healthy society. So it would be good if we can prevent some of those adolescents and children from becoming obese in their 30s and 40s. But to do that, we're going to have to make the social changes in the society.
Yeah, I was going to add as well that because it's now off patent, at least semaglutide, the cost is coming down. So that's going to be a big game changer. And also the access, because that was one of the things that we were discovering because of the obesity indication, there was none available for a lot of the developing countries. So it was all being used in Europe and North America. So even if you had access to it, availability was an issue just because of the competing demand from countries which can pay better. But now it's off patent. And I think there's a couple of companies that are manufacturing the biosimilar semaglutide. I don't think the Mounjaro teriparatide is out yet, but I think that's maybe just a matter of time. So yes, it will be a big game changer. And then I have used it a lot for a couple of patients. For me, the patients with diabetes and nephropathy, especially when you have them on everything already, it's like you're seeing the proteinuria not checking and so on. Then you say, well, we have to get the weight down. If not, we're looking at dialysis. And so that's really where I've kind of pushed them. Cost is still high for the methods, the options that we have here. And for the administration, it's not much different from administering insulin. So a lot of patients are able to move. It's a pre-filled pen a lot of times. So you just dial and stick, and it's once a week. So a lot of people are more open to it. In fact, can't tell the last time I've had somebody go for bariatric surgery. And I think, I don't want to say it on this, but I think the surgeons are using it more than. Anyway, I won't comment. It's just that I haven't seen anybody going for surgery recently, and I'm wondering why. Mhm.
Yes, thank you. And yes, we can understand why. Yes, we do know some of the surgeons are using the GLP-1 agonist. Any questions, Sam? Because I'm still not seeing this Q&A.
There's one question. Thank you, Prof. Tollereed. What do we do since only one lab is standardized using HPLC to use HbA1c to confirm diabetes?
Right. So kind of thinking around the issues. So as I said, there's only one lab which is recently using the method. I don't know if it's DCCT, if they're using a DCCT standard. So there's a couple of things that you have to remember because there are methods which are approved. But whether you're using a standardization process, which involves this common sample that validates the methodology used in each lab, I'm not so clear on that, but the method is better. So I still tend to rely a lot on the traditional glucose tolerance test, recognize the fasting glucose a lot of times will work, but if you have a high suspicion, going for the glucose tolerance test is the way to go. Remembering too that there are a couple of patients that will be missed from fasting glucose, especially older persons. Those are the ones that I tend to say, well, if the A1C is kind of throwing out something and yet the fasting glucose is okay, this is a person I would say go ahead and do a formal glucose tolerance test. It's probably the most sensitive, even though there are errors that can be associated with it, but it does tend to pick up people with abnormal glucose best. So when there is so usually the American Diabetes Association talks about what to do when the tests are not consistent, meaning that you have your fasting glucose is not consistent. Your A1C is not one is abnormal. So the fasting glucose is normal, but the A1C is high, or the total glucose is normal, whatever it is, but the A1C is high. So whenever you have that, they usually still recommend repeating the test, which is abnormal if you're not sure, and especially if the person is asymptomatic. But again, if you're repeating the test, you have to know what you're sending them back to do. So if you're doing an A1C where you're not certain about the validity of the measurement, repeating it may not be helpful. And so a lot of times I just go straight for a regular 75-gram oral glucose tolerance test and use that as my guide.
Thank you so much, Prof. For Prof. Ferguson, what evidence-based interventions have been shown to produce the most sustainable long-term weight loss and health benefits for patients living with obesity?
So, in terms of long-term evidence, the bariatric surgery is still would be considered the gold standard. The issue, of course, is cost, potential side effects, patient selection. What we will need to see over the next few years is the long-term use of the GLP-1 agonist. So in terms of, as you know, the lifestyle interventions, the adherence tend to wane after a while. So many patients tend to regain the weight. The initial studies are suggesting that if patients come off the GLP-1s, that they also regain weight. So whether they may be able to be maintained on, say, a lower dose after they've lost weight, along with lifestyle management, etc., is still to be determined. So we know that they're effective in the short term. We don't yet have the long-term data. But if you're to look for long-term data, bariatric surgery would have the longest data. And I guess it's just a matter of time. Bariatric surgery has been done for many, many years, whereas the GLP-1s have been around for just about 10 years thereabout.
Yeah. And I was going to add, just from my experience to that, I find that the patients do better if they have a combination of both. So I mean, they'll lose weight with the GLP-1, but definitely they do better if they also include the lifestyle, the exercise as well. So sometimes I've been going up on the dose and then you're not seeing any change, and then once they start adding some exercise to the routine, it makes a big difference. And then of course, the bariatric always has an issue with the long-term effects, especially the more radical procedures. So, the vitamin deficiencies, B12, vitamin D, concerns around calcium, adequate calcium intake, and bone loss. I think the GLP-1s, so far, the main things coming up is around the sarcopenia. So they lose a lot of muscle mass because they're eating less of everything, less protein. And so you have a lot of weight loss, but a lot of muscle mass loss, which is not necessarily how we would ideally like people to be changing their body composition. Yeah. So
Thank you so much from both of you. Prof, how would you define exercise in this instance? What is exercise?
Exercise. Okay, that's me. Exercise. Well, you have to go to the guidelines. Ministry of Health 2024 guidelines. Trevor, I'm giving you a promotion here. So we sustain physical activity. Usually we are recommending some form of a combination of not just cardiovascular, which is your walking or other cardiac exercise, but also some form of weight training. And usually we're talking about consistent physical activity, which is not going more than 2 days without some form of exercise. So it's not just weekends and then nothing again. Yeah, because the benefits, of course, go once you are not doing it consistently. So that's really what I'm talking about. I mean, we can talk about exercise because we know that for different people, there are things that you can do differently, and there may be different strategies that you use for physical activity depending on age and other circumstances.
Right.
I try to encourage them to do the water exercises a lot. I don't know if we have to think about that as another thing for population, because I find that a lot of patients, I think, could benefit from some of the water exercises, but the options are really in Kingston primarily. And then I also encourage them to do some of the television programs. There's a couple of them which I use for older persons, which are not kind of overly stressful, but quite helpful when it comes to improving balance and other things, which are also important benefits you want to see come from exercise.
Thank you, Prof. So the final question is for both of you to chime in. If there's one change you would like primary care providers to make tomorrow to improve long-term health outcomes, what would it be?
All right, so I guess if we're to look at that, it would be to begin to introduce the discussion on obesity and weight management much more frequently in our practice. So we see the patients. So first of all, everybody should have weight done at every visit. That would be a good idea. And of course, heights at first visit, and at least we're monitoring their body weight and having a discussion around that so that we promote healthier weights. Yeah, too many patients come in, they get prescription for everything or for other things, but there's no discussion about body weight at all.
Then I think for me, because of what the project I'm in, I said blood pressure. I'm a blood pressure believer. I've taken over from triple. So, I mean, and just in terms of as a risk factor, which is modifiable and can make a big difference to long-term survival, risk of kidney disease, heart disease, stroke, dementia. I think that's really one thing I would say is either figuring out how to improve measurement in office or really encouraging a lot more self-monitoring of blood pressure. I can't say which one is going to be best, but I think that I think could be a big game changer for the region. If we can get that right and address it more aggressively. I think it's an easier fix than obesity. So I go for a low-hanging fruit. That's what Trevor says. I must go for a low-hanging fruit. So that's my low-hanging fruit. Better blood pressure control.
Prof.
And
Tollery.
on
Prof.
that
Sorry.
note, can I encourage everyone to do the PAHO course on blood pressure measurement and get your certificate so we can show off as well, not to show off, just get your certificate and get your nurses in the clinics, in your practices to do that blood pressure course as well. I think that's very important. That certainly was an important takeaway for me. And one other point as moderator, I think we should certainly lobby with the NHF to give everybody a blood pressure machine, just as the diabetic gets the glucometer. More costly, but perhaps all round more effective in saving lives and reducing morbidity. Who knows?
Thank you so much, Doc. Thank you, Prof. What an awesome presentation. Before we go to Dr. Williams-Green to introduce our vote of thanks, there's a video from the CCFP for you all to enjoy.
Okay.
Join the Caribbean College of Family Physicians, CCFP. Your pathway to professional growth, recognition, and global networking. As a member of the Caribbean College of Family Physicians, CCFP, you become part of an elite network committed to advancing family medicine across the Caribbean. Membership opens the door to local, regional, and international opportunities for professional development, accreditation, and leadership in primary care. Earn CCFP CMEs, recognition that counts. The Education Committee delivers a 3-year curriculum tailored to the realities of family medicine practice across the region. Achieve your MCCFP certification by completing a minimum of 50 CME hours annually, 150 hours over 3 years, to earn certification, a respected professional credential locally, regionally, and internationally. The MCCFP designation, a pathway to professional recognition. For physicians who have successfully completed the Doctor of Medicine, DM, in Family Medicine program, an important next step in professional development is obtaining the MCCFP designation through the Caribbean College of Family Physicians, CCFP. The MCCFP designation signifies that a physician has met the standards established by the College for Postgraduate Training in Family Medicine and demonstrates a commitment to continuing professional development and lifelong learning. Physicians who apply for membership in the Caribbean College of Family Physicians within 3 years of completing their DM in family medicine are eligible for full membership and are awarded the MCCFP designation upon admission. Physicians applying after this period may still obtain the designation by demonstrating compliance with the college's continuing medical education requirements. The MCCFP credential serves as a recognized professional qualification within family medicine and provides evidence of ongoing engagement in continuing medical education, professional standards, and regional collaboration among family physicians. The college requires members to maintain continuing medical education activities and remain in good standing in order to retain the right to use the MCCFP designation. For graduates of the DM Family Medicine program who aspire to specialist recognition, the MCCFP designation represents an important professional milestone that demonstrates commitment to excellence in family medicine, quality patient care, and lifelong learning throughout their careers. We encourage all family medicine graduates to become active members of the Caribbean College of Family Physicians and to pursue and maintain the MCCFP designation as part of their professional journey. Access a rich calendar of CME opportunities, monthly workshops on seminars, and an annual family medicine conference. Monthly CME meetings with certification. Online CME courses and training modules in collaboration with recognized regional and global health bodies. Tri-annual Pan-Caribbean conferences and WONCA international and regional conferences. Diverse, high-quality educational content. Our CME programs cover clinical updates in hypertension, diabetes, obesity, HIV/AIDS, and occupational health. Disease management guidelines from PAHO, WHO, CAREC, and CHRC. Evidence-based approaches to disability management, patient safety, and community health. Local, regional, and global connections. Collaborations with the University of the West Indies, UWI, Caribbean Food and Nutrition Institute, CFNI, ACOM, ICOH, and other leading institutions. Opportunities to present and publish peer-reviewed research at regional and international conferences. Flexible CME credit earning. Members can earn credits through group learning, workshops, seminars, symposia, hospital grand rounds, individual learning, online courses, journal clubs, publications, presentations, and voluntary community work. A commitment to lifelong learning. CCFP members benefit from structured guidance, CME tracking, and annual submission of CME credits, ensuring compliance with the highest professional standards. Join the CCFP today. Elevate your practice, expand your network, and gain the professional recognition you deserve. Contact the Secretariat to start your membership journey.
That's it, Doc.
Sorry. Thank you so much. Dr. Dane Levy will now do the vote of thanks. Thank you.
I'm not seeing where Dr. Dane Levy is with us at the moment. So,
All
on
right,
behalf,
I'll do the vote of thanks. Dr. Levy, always very hardworking member of the committee. I'm happy to help out. Want to thank, first of all, our presenters, excellent presentations, Professor Trevor Ferguson and Professor Marshall Toller Reed. And they always make themselves available for giving professional opinions. Would like to thank the prayer that was done by Dr. Arlene Henry Dawkins. Thank her. Thank our president of the CCFP Jamaica chapter, Dr. Seni Onanuju, for the greetings and overview. And of course, our sponsors who had to make our meetings cover our costs. And these were Abbott Nutritional, Paul Russell, and Indus Life Sciences. I'd like to thank Sam Heron, who has conducted the audio visual and also helped with the moderation. behind the scenes work, excellent support from him. Thank you for his technical support and otherwise. We'd like to thank our secretary, Mrs. Lynn Hyatt Thompson, as well, ensures that things go freely. Again, we thank our presenters. We thank all the participants who gave up fee for World Cup and otherwise to join us. And I'm wishing you all a pleasant afternoon.
Yes.
Good evening.
Thank you. Have a good evening.
Thanks, everyone. All the best.
Thank you so much. Have a great day, everyone. Cheers.
Thank you very much. Very much. Thank
Hi,
you.
Dr.
Good
Nojo.
evening.
All right.
Let me just thank our moderator as well. She wouldn't thank herself, Dr.
Yeah.
Williams Green. Thank you so much.
Welcome, Sam. Bye.